Dr. Roberts, welcome to the Nailed It Ortho podcast. We are happy to have you on. So, welcome to the podcast.
Thank you very much for having me. I'm excited to talk to you guys about scaphoid fractures.
Oh yeah, I feel like we learn like the very general details in med school, and then you learn a little bit more in residency, and then it's not, of course, until you're in the hand rotation until you can dive a little bit deeper into scaphoid fractures, which I'm actually on my hand rotation now. So I'm looking
Yes.
forward to the talk. So we typically start off, just asking a couple questions, getting to know you, and then we get into the topic in a while. So, first question, just a general question, Mitt, what interested you in hand, or what made you kind of choose that specialty?
I love hand because I don't have to choose a specialty almost. So I get to work on arthritis. I get to, do sports cases. I get to do some more kind of plastic surgery type of stuff with flaps and nerves. I get to do trauma. So I still get to use all of those skills. And I do enjoy the micro work. You kind of have to like some of the micro. That's part of the job. So that's kind of what drew me to it. I got to do all the things that I had studied in residency.
Yeah, yeah, it's a lot of yeah, I didn't realize that until maybe a couple of weeks ago. Actually, I was talking to another hand guy. He's like, "Oh, I actually do total shoulders, total elbows. I do all of it." So I was like, "Oh, I didn't thought it was just like hand." So I've
No,
definitely
I'm,
learned
I'm a
some.
full upper extremity surgeon.
Yeah, no, that's pretty cool. So for those listening that may be interested in hand, just keep that in mind. Another question we have is: are there, now that you're attending, you did your years of residency, you did your fellowship training, are there any habits that you have got as an attending that you didn't have as a resident, like things that you start to do that you notice that you wish you did earlier?
Well, I think as an attending, you have the time to sort of, you're really just immersed in your specific field. So you really are just honing your fine points in the beginning of your practice. You've learned all of the stats and the facts, and you're finally getting to know the character of these different sort of patient types and injuries and things like that. And that's what makes it really kind of fun. Um, I don't know, as far as like habits that I still continue from my residency and fellowship days, I definitely was a big note taker in my notebook. I had my little black notebook like a lot of us have. And then, as things like Evernote became popular, I would just take pictures and, upload the pictures and the x-rays along with op notes and papers in Evernote. And I still do that even today.
Yeah, Evernote is I love Evernote. I use it for the same thing. I've been using it more and more lately. But for those of you listening that do not know what that is, go and check it out. It's an app that you can, just like Dr. Roberts said, you can put notes, you can put pictures in there. It's easy to organize, and this is by no way a paid ad or anything. It's just that we both use Evernote.
But
um,
I drew a lot in my black book, and hand surgeons talk a lot about drawing sort of different anatomic structures to better understand them. You'll always hear the stories about Littler drawing all the hands, and you can actually even go visit his drawings in the New York Museum.
oh, I didn't know that piece of information. That's actually pretty cool. Um, cool. And then just moving on, do you have any other interests or any things that you do outside of medicine? It can be whatever.
I definitely enjoy working out. I have both the Peloton bike and the Peloton tread down in the basement. So
Nice.
that's how I've
Awesome.
been keeping sane here during the pandemic.
Yes, I know a lot of other, orthos are doing the Pelotons, and a lot of people in general has really like picked up popularity over this past year or two. I have yet to get one, but I heard it's great exercise and a fun time. Um, so just moving on, I guess we'll get into what our talk for the day is. We're going to talk about a little bit about scaphoid fractures. So Dr. Roberts, say for example, you're consulted. You had a 25-year-old male football player who fell down onto his outstretched wrist. He had pain, and it's been about 3 weeks. He came in and they noticed that he had a scaphoid fracture. Before we get too far into the history and physical exam findings, can you kind of just go over just some of the anatomy of the scaphoid and the important parts to it?
Sure, sure. So the scaphoid seems like shouldn't be a big deal, right? I have such a hard time convincing my patients that it requires all of this fuss, as my husband, the trauma surgeon, likes to say, I could swallow that bone. Why do I care? Um, but it's actually, as I explain to my patients, it's like the keystone of the wrist. It links the proximal and the distal carpal rows. But the problem with it is that it's 80% covered by articular cartilage, which doesn't leave a lot of area for blood supply to get in.
Mm.
So the vast majority of the blood supply comes from direct branches from the radial artery that come through the dorsal ridge at the level of the waist. And that accounts for about 80% of the blood supply to the scaphoid. The proximal pole gets its blood supply retrograde, which accounts for the fact that a lot of the proximal pole fractures go on to non-union or avascular necrosis. And then the distal portion of the scaphoid actually gets some blood supply from the volar branches. And then what else can I tell you about I think
What
this
about
is
like
just
the
point.
the ligaments? I always hear about like the ligaments and like the scaphoid wanting to flex. Like what do I guess a role as far as I guess scaphoid mechanics or I guess that's a word, mechanics.
Yeah, so the distal portion is attached to the trapezium and trapezoid, and then it also has like the radioscaphocapitate ligament volarly, which almost acts like a hammock. So it kind of like, bends over that. And then your proximal fragment is still going to be attached to the lunate, which wants to go into extension. And that's what creates that classic humpback deformity.
Yeah, I always hear about. Well, I don't always hear about that, but I heard about it for the first time a couple of weeks ago, and looked it up, and I figured out, that humpback deformity. Just like you said, that distal fragments flex from those attachments to the trapezium and the scaphoid, and the proximal fragment kind of extends from its lunate and triquetrum attachments. Now, in your practice, what I guess the epidemiology, what age group do you typically see this in? Do you typically see this in males, females, young, old, active? Like is there anything that stands out to you?
I mean, it's very well established. This is more common in men, and typically, I would say we mostly see younger men, but you definitely see these fractures in kids and in a little bit older adults. I think they're more rare in the like truly geriatric population because most of those people are going to get distal radius fractures from fragility. And then it's typically, they've done studies on this. You have to fall in about pronation and ulnar deviation with hyperextension past 95 degrees is what the biomechanical studies have told us.
Wow.
Um, but essentially, the volar cortex is going to fail in tension, and then the dorsal cortex is getting, compressed.
Okay. So, important things to know about scaphoid. Number one, the blood supply. Most of it, comes from those dorsal branches of the radial artery. It's mostly covered in cartilage. Um, and and we spoke a little bit about the blood supply, not the blood supply. We talked about the attachments of the different ligaments, which flexes that distal piece and extends that proximal piece. Now, are there any classification systems I know there are like a bunch out there, but are there any that you necessarily use or refer to most of the time?
I wouldn't say that any of us use these a ton, but there are two sort of classic classification systems. The first one being the Herbert classification system, which first defines, an A versus a B fracture, A being stable and B being unstable. And there's really only two stable fractures. That's the tubercle fracture or distal pole type of fracture, or an incomplete waist. And then everything else is considered unstable. So that's your waist fractures, that's your proximal pole fractures, anything with any displacement. And then he further goes on to sort of categorize ones that show up late, like a delayed union, and then non-unions. And he does sort of go on to classify non-unions into fibrous and avascular necrosis, et cetera. But I wouldn't say that's all super useful. There's another classification, the Roos classification, and that's based on the orientation of the fracture line, which he defines as horizontal, oblique, transverse, or vertical oblique. And then he says that the horizontal oblique fractures are the most stable because they get some compressive force. And then the most unstable ones are the vertical oblique because they're getting a shear force. But again, I wouldn't say that's something we talk about a lot when we talk about these fractures.
Right. Is it kind of just more something that you look at just so you know, like, at least in your head, whenever you see a fracture, so okay, that's likely going to be unstable, given the orientation of the fracture lines and where it is. And I guess it may just be a good thing to know. That way is it easy like to predict displacement or predict that, maybe fractures of proximal pole may be more prone to AVN, or it was kind of just a general ways to just think about these.
Yeah, I mean, I'd say that A versus B is the most important distinction. Is it inherently unstable and likely to go on to non-union if we don't do something about it, or is it probably going to heal just fine in a cast? And almost all of your tubercle fractures, and especially, your partial fractures through the waist, are going to be fine in a cast. Anything after that is a little bit of like an art and opinion.
Okay, totally understand. And again, for those listening, stables, you said it about 3 times. We'll say it again. Those tubercle fractures and those incomplete fractures, definitely like an incomplete waist fracture would be a stable fracture. Now, rewinding all the way back. So, say for example, we had this patient, this 25-year-old guy, fell three 3 weeks out, still has wrist pain. When they come to your clinic, what are some of the things that you um, think are important to look for on history and physical exam?
So I think a lot of our sort of initial responders to these fractures know that scaphoid fractures are something that are often missed, and so um, it's almost unusual these days that someone does come in 3 weeks, but it's not impossible. So the first things that they're always taught to look for, and you guys should look for, are scaphoid tubercle tenderness, as well as tenderness over the anatomic snuff box. And I would say either one would make me suspicious. I've seen plenty where they're just tender over the tubercle and it has a waist fracture. And then there are some other things like the compression test, where you basically push the thumb metacarpal into the scaphoid, and that should elicit some pain. I wouldn't say we use those terribly often. The main ones we do are the snuff box and then the tubercle. I would say some other sort of clues. A lot of these don't have a bunch of swelling. And so what I often see is, a kid comes in, or, a teenager comes in with their parents, and they're like, we went to the urgent care. They said the x-rays were negative, but he's got this big bruise. So they will often have kind of a suspicious looking bruise, and that should also clue you in. It can be volar or dorsal. A lot of times it kind of follows the FCR. And then, then you've got to get some imaging, obviously. So, classic imaging is PA lateral oblique. And then if you're suspicious in the office, you want to get a scaphoid view, which is essentially a supinated PA in ulnar deviation. But about 25% of those with a scaphoid fracture won't show up as, positive. By 3 weeks, you probably would have had positive x-rays.
Right, but initially those will likely be negative, and then within a couple of weeks they'll turn positive. Now, one of the things that I was thinking about as far as physical exam finding, is there anything else on your differential when they come in for wrist pain on that radial side, or any other things that you may have seen in your practice that are maybe hiding in the behind the trees as another diagnosis of what might be going on?
I mean, they can certainly have non-displaced distal radius fractures. Um, Trapezium fractures are unbelievably rare. They could certainly have a fracture at the base of the thumb. Um, so that, those would be sort of in my differential. They could also have just like a ligamentous injury. So you have a scapular injury that doesn't show up on the x-ray, like you don't see any widening. Some of my mentors would certainly include a pencil grip view in the standard views for a scaphoid workup.
Huh. Pencil grip is that not that's not the same as a clenched grip, I assume. Is that
Uh,
just
yeah, it's a clenched one, but they like are holding a pencil at the same time.
ah okay. Okay, that makes sense. And do you get the scaphoid view, and I mean, do you just get them for all the ones that you're worried about fracture? Like you get a normal PA lateral and oblique, and then you don't see it, and so you try to get that scaphoid view in that sense, or is it just sometimes that you get it, or all the time?
I wouldn't get it for every wrist trauma. I would just get it if I suspect it from my exam. So most of the time they've gotten their 3 regular views, and then I suspect it on exam and I send them back for the scaphoid view.
So at what time generally move forward to like more advanced imaging, like a CT or MRI, or is there even a role for a CT and MRI in your practice?
I think there's definitely a role. The question is, there's a lot of controversy right now about how exactly you should use these and when. So I know the classic teaching that maybe we've all read about is, you suspect it, you cast it, and then you bring them back in 2 weeks and get a new x-ray and it should show up by then. But that's 2 weeks of casting, usually in a young person who's not going to tolerate casting very well. Um, so a lot of times we jump to advanced imaging. And especially, in 2 weeks, if it's an unstable pattern, you've already, you will have seen some displacement in that time. That's definitely happened to me. So you want to catch it before it does displace. So I would definitely jump to some advanced imaging before waiting 2 weeks. And I think most people are in that headspace too. And so MRI is certainly the most specific. I would say it's probably about 100% sensitive and specific. But as a surgeon, that doesn't give me a lot of information.
Right.
It really doesn't tell me about the orientation. It'll often just sort of show up as this like white cloud.
Yeah.
And it doesn't really tell me about the displacement. So it's too much information almost. So I often will use MRI in kids where I don't, kids heal so well that it's very rare that I'm going to be fixing a fracture that didn't show up on the x-ray. So I'll get the MRI to prove that they have it and prove to them and their family that they really do need to put up with this cast. And, then I know that I don't really need any surgical planning from that imaging. But for adults, anyone I would probably want to fix, I'm going to get a CT scan because that's going to show me the character of the fracture and what I need to do to fix it. And it's also much more sort of sensitive for any displacement. You really can't get a good idea for displacement on the MRI.
Okay. And so again, just looking at the timeline. So say for example, if somebody has negative x-rays in the ED or the urgent care center and they're, teen or kid, adolescent, refer to your clinic, you see them, they still have that tenderness right in that snuff box area, the tubercle at that point, and you get another repeat, x-ray there and you don't see anything. At that point is when you get the MRI. Is that correct? Or
So,
CT?
I mean, actually, in our institution, Dr. Starch did a study on the cost effectiveness of this. If you have a positive exam and negative X-rays, you get a CT scan almost right away.
Okay. So like down in the ED before they leave, they did get
Mm-hmm.
that CT scan.
Yep.
Ah, okay. All right. Okay. Cool. Now, because that's one of the things that you sometimes hear some things and hear other things, and you're trying to figure out what's the best way, what's the best timing, to get everything done and get these images. So that's definitely good to know. And so when it comes to treating these fractures, what is your overall algorithm as far as what are some things that you undergo non-operative treatment, and then what are some indications for these fractures to be fixed?
So your non-operative fractures, like your tubercle fractures, your partial waist fractures, your truly non-displaced fractures, you're going to treat non-operatively in a cast. And I think the controversy about this is probably over, but some of us are still sort of holding on to the way that we've always done things. Um, you know, we used to make a long arm cast with a thumb spica. And now I think most people have gone to just a thumb spica cast that's short arm. But more recent studies show that you don't even need to immobilize the thumb. I think in fact, in that study, the just plain short arm cast had a slightly higher rate of union, which I
Yeah.
don't, really means, a lot, but you're certainly fine to just put these in a short arm cast. That being said, a lot of us have I myself have trouble letting go of the thumb spica. So I would go with whatever your attending preference is on that one.
Right. Yeah. And you just hit all the points I was about to ask, because I read some places that just said, yeah, you do the thumb spike, not the thumb spike, the long arm cast, because it helps control, some rotation, and then some with the thumb. And then apparently, just like you said, there's some studies that say you don't even need to include the thumb in a cast, and they tend to heal just fine. So really dealer's choice, I guess, as far as how you treat these.
Yeah.
And what's your algorithm? So say, you have an incomplete, waist, or you have a distal pole, or, a distal tubercle or a non-displaced fracture. What's your algorithm? Do you have them in a cast for 4 weeks, and you transition them to a short arm to a removable wrist plan, or what do you know? How do you kind of go about as far as progression?
So the tubercles, distal pulls, things like that that get good blood supply, they will often heal in about 6 weeks. But a truly non-displaced waist fracture that you're treating non-op is probably going to take more like 8 to 12 weeks. So I'm definitely following these guys regularly. And as soon as they don't have any tenderness on their exam and it's looking like there's some union on the X-ray, I'll start to free them up a bit. I like to keep immobilizing them in something, like either like some type of thumb spica orthosis made by the OT, or just like
Mm,
a Velcro thumb spica, something just to remind them that it's still healing,
right.
and then get them into therapy to get their motion back.
Okay. And so, we have our patients that we know that are going to undergo the non-operative management. So, what are the indications that say, okay, well, this is probably something that we need to bring to the OR?
So this is where I was talking about there's a little bit of art and opinion. I think a lot of people are of the opinion that if you can see a fracture on X-ray, then it is by definition displaced. And I'm personally coming around to that opinion.
Yeah.
Or it's at least, by definition unstable. So it's probably going to move on you when you take an X-ray in 2 weeks, and then you're going to wish you'd already done surgery. Um,
Right.
so anything with, a millimeter of displacement certainly needs to go. The proximal pole fractures you can't trust to heal on their own. So I would certainly put those in your operative group. Um, and then, other things you might sort of want to look at are there any sort of like greater arc injuries, so that's the sort of fractures around the lunate that I might think, might portend some instability as well. Things like triquetrum fractures, ulnar styloid fractures, things like that, that might give me a clue that there's more ligamentous damage than you might initially think.
Right. And just reading and I guess preparing for this, there are some studies out there that were, talking about casting versus fixing acute fractures, and that at 2 years that they were about the same, but earlier on, they had some benefits. In your experience, have you noticed any change as far as if you cast versus if you fix them,
I
those
think we're all getting
borderline fractures?
more aggressive about which ones about going ahead and fixing, particularly in young working people or athletes. We just want to get them back to work for their sports, so we'll go ahead and fix them, with just the notion that they're unstable, that fracture pattern's unstable, and we should just go ahead and fix it before it proves itself to be unstable.
And is there anything that you're looking at on the X-rays, or I know there's like a million and one different type of angles for, in the hand, but is there anything in particular that you look at that you take into account as far as, I guess, preoperative planning?
So things people talk about are a scafolunate angle greater than 60 degrees, and a radiolunate angle greater than 15 degrees. And then some other things people talk about are an interscaphoid angle of greater than 45 degrees. The normal interscaphoid angle would be 24 degrees. I would say I honestly don't use these as much as maybe I should. Like a humpback is pretty darn obvious.
Right. Yeah, you can tell.
So I wouldn't, those are good things to know for your tests, but you're not going to be able to miss a humpback deformity when you see it on an X-ray. And maybe one thing I should go back to CT scans is you really want to make sure that they're in the plane of the scaphoid, because you can definitely miss a fracture if it's just in the plane of like the radius, which is how they're typically formatted. And when you guys are out on your own, you might have to actually like talk to your radiologist to get them to format that way so that you don't miss anything.
Right. And just thinking about it, so the radius, I mean, not the radius, the scaphoid is tilted volarly as well as radially, right? So it had to be in that oblique plane.
Exactly. Yeah. So it's
Yeah.
it's totally possible that if it's not in that oblique plane, that you could miss the fracture.
Hmm. These are all nuggets for any of you residents out there that may be listening to this, that has a scaphoid coming in today that's unquestionable, that you're getting a CT scan for. Don't forget to put in the comments to have it in the plane of the scaphoid. So just moving forward, so we decide we're going to fix it. Is there anything that how do you decide whether you're going to go volar versus dorsal, like the approach that you're going to take to the scaphoid?
So I'm just gonna get on my little podium here for a second. There are lots of things in orthopedics where you get to pick which way you like to do things. if you're going to fix scaphoids, you have to be a jack of all trades. So you can't just be like, oh, I like to fix these dorsal, or oh, I like to fix these volar. I like to graft this way. I like to graft that way. And you certainly got to have a few even, vascularized graft tricks up your sleeve, because these are all different. They have their own little characters, and you have to really study them on the CT scan to figure out what the best way to go about it is. So if you just have a straightforward waist fracture that's minimally displaced, you can really go volar or dorsal. Some people like to go volar just because it's a little bit easier maybe to get the angle of the screw, but you are going to run into the trapezium, and sometimes you have to nibble a little bit away of it to actually get your good starting point. You kind of want your starting point a little more dorsal than you may have access to. And you want it kind of a little bit like a third in from that most radial corner of the scaphoid on the AP view. And another thing that's really important about fixing scaphoid fractures is the placement of your screw. So you really want to make sure that you're center in the scaphoid and that you're 90 degrees to the fracture plane. So studies have actually shown that really being 90-90 gives you better compression and better chances of healing.
Right. And are there any cases that I think I just jumped to open versus, volar versus dorsal, but are any cases that you'll do percutaneously, fix a scaphoid?
Yeah, so you can do perc or mini open volar and dorsal. Percutaneous, often people will use like a large bore needle and put the K-wire in through that and then just make like a tiny incision. I would say I typically use like a mini open approach and make just like a tiny T in the capsule in order to get like a good view of my starting point. But if you have a non-displaced one or minimally displaced one, that's like a very popular way to fix it.
Okay. And another, I guess, style point question that I had, what tips do you have for, I guess, if we'll go about the volar approach? If I remember correctly, like when you're down in the capsule, there's a certain way that you'll make you make your incision or I guess your capsulotomy in line with the ligaments. Is that correct? Is that what you
Yeah, I mean,
do?
I usually just make it like straight, sort of longitudinal in line with the scaphoid. But I would say the trick to not causing any instability is to tag them. So as soon as I make my capsulotomy, you can really see those two ligaments very clearly. And so I just tag them at the beginning, and then I sort of bring them behind the wrist with like a snap, and that way it keeps that flap open for me the whole case, and I don't lose them.
Okay. So one of the things definitely to be on the lookout for is to make sure that you don't cause instability with your approach. And then to tag everything like you just said and then repair it at the end. Okay. Um, so I think we spoke a little bit about, some it's kind of dealer's choice as far as which approach that you may take, open versus dorsal. Do you ever use a arthroscopy, or do you ever use arthroscopic assisted approaches
I would
at
say
all?
I don't have a lot of experience with that, but it can definitely give you a better idea of any surrounding ligamentous injuries. Um, I know that some surgeons do it, but it's not necessarily in my wheelhouse.
Yeah, yeah, I know. One of our shoulder and elbow guys loves to do, arthroscopic surgery. So I'm sure there's a way. Actually, I saw my first wrist scope not too long ago. It was actually pretty cool. Um, but yeah, I think that's a dealer's choice as well. Now, do you have any tips and tricks for a dorsal approach to the scaphoid? And actually, do you mind just walking us through what that approach would look like?
Yeah, absolutely. So you're gonna sort of find your Lister's tubercle, and you can go kind of straight in line with it. And that starting point is where right where the scapholunate interval or ligament inserts is just slightly ulnar to the Lister's tubercle. So then, once you've come through the skin, you're gonna look out for EPL and your second dorsal compartment and make sure that those are retracted. And then you're gonna basically be down to your wrist capsule, and I will make like a small T-shape capsulotomy in order to see my starting point. And usually, if it's pretty non-displaced, then I will try to, not to disrupt as much of the sort of dorsal capsular attachments for obvious sort of vascular reasons.
Yeah.
But sometimes that's like really already disrupted, and that's how you sort of get your reduction. If you do have to like lift the capsular flap up that much, you can use joysticks in the proximal and distal portions in order to manipulate it and get your reduction. Another great thing about the dorsal approach is it's a great place to take bone graft from. You can just pop blisters tubercle off with an osteotome, and then just get some great bone graft from there and put it in there if you need to use that to help with healing or with to get your reduction a little bit. Sometimes if there's some comminution, you want to stick some graft in there. That's always nice. My trick for getting the starting point, you kind of want that little corner just at the edge of the scapholinate ligament. And I find that if you just let the wrist flex down naturally, and they'll tell you it's about 45 degrees, but whatever is natural for that person, you want to get as volar as you can. So you're in the center, and you let the thumb metacarpal sort of fall where it falls. I find if you put your K-wire in line with that thumb metacarpal, you almost always get it where you want to.
That's a good tip right there. I might use that coming up soon. I think I have a couple scaphoid cases coming up next week, so that may be something that we'll pay attention to, or at least I'll sound somewhat smart. Like, shouldn't we, go online? Oh, how'd you know that? Oh, I don't know.
I think you're just in touch with the force, the KY force.
Now, one of the things that we had a case not too long ago, we had one of those humpback deformities. We did a volar approach, but in your experience, do you have any preference as far as a volar versus a dorsal approach for patients that have those scaphoid non-unions with that humpback deformity?
So I mean, if you've got a humpback deformity just from a regular scaphoid fracture, you've got to go volar. But I think you're starting to get into an important point, which is you cannot talk about scaphoid fractures without talking about non-unions and how to fix them.
Yeah, let's get into it. What do we got? Go for it.
So, I mean, as you guys know, these often get missed, so they're showing up late. And the studies have shown that if it's more than 4 weeks with no treatment, then they're going to have a pretty poor chance of healing with non-operative treatment. And you'd be surprised how quickly these go on to have sclerosis and cavitation, even in a really young person. So in that case, you're going to have to do something to re-stimulate healing. Which means you're going to have to scrape out the non-union site, and you're going to have to put some graft in there, and you might have to correct some deformity. On rare occasions, sometimes the cartilage capsule, it's all intact. I see this a lot in more like proximal pole fractures that have gone on to non-union, and there's some cavitation. And those are the ones where you're going to get away with a more dorsal approach, and you can basically, put your K-wire down, and then over drill it, and then you can shove some graft down that hole, or you can even use like a very small curette to clean out any cavitation, and then put the graft down the hole, and then go ahead and put your screw down. And those seem to have a pretty good chance of healing that way. The vast majority, however, have gone on to some horrible humpback deformity, and you're going to have to go volar. So there's a couple of ways of non-vascular grafting. So the most classic initial one was basically to take a large sort of trapezoidal, not even trapezoidal, almost like a square chunk of bone graft, and put that into the deformity and use that to correct your deformity. And initially they didn't even use any sort of fixation, so no screw or no K-wire. And then the Bruce technique involves like 2 matchsticks that you would take from the volar distal radius, and basically use those to almost like a tent pole to open up the fracture. And they would just put that in there, maybe with some other bone graft, and again, no sort of fixation. But modern techniques pretty much all involve screw fixation. There's really not much of a role for even K-wires anymore, other than like a derotational wire or anti-rotational wire. I myself use the modified Roos technique, which I learned from Dr. Lee in fellowship, as well as Scott Wolf, who've written a good paper on how to do it. So basically that takes the matchstick to prop open your humpback deformity, and then you're going to pack the rest of it with graft from the big hole you made in the radius. Yeah. And then you basically use a screw to parallel the cortical matchstick, So instead of two cortical matchsticks, you have a one matchstick and a screw. Another way is, I think the Fernandez Fisk is what it's called, which is that one sort of like almost a triangular trapezoidal wedge that you can shove in volarly. And that has good union rates, but it's very finicky. It's really easy for that little puzzle piece to just pop back out at you over and over again, and you slowly
Right.
lose your mind.
Go crazy. So I mean, there are all these different techniques. How do you? Is there? I guess one is there an indication to use one versus the other? I know maybe some were just more historical. Then how do you decide which one to pick a non-vascularized bone graft? I guess what technique to use.
So I mean, if you've got avascular necrosis, like it's really just like not coming back, then you're going to have to use some sort of vascularized graft probably. And then you're really like in the salvage area, you're using like the rib osteocondyle graft or the medial condyle graft. Um, but I would say nowadays, a lot of people are coming over to the side that you don't need to use as much vascularized graft. And maybe I'm wrong, but that was certainly the way things were leaning, when I was finishing up my training. So really what I think helps you is doing a good cleanup of the whole area. So when you get in there, it's even in a young person, it's going to be like white, really, really hard, surprisingly hard for such a tiny bone.
Right.
And so you've got to really scrape it out, like really work at scraping it out with the curette. And then you've got to do something to sort of stimulate some bone healing. Like I'll often use like a smaller K-wire on both ends to stimulate some ingrowth. And if you've got some punctate bleeding on either side with that, you know that you're gonna, if you do everything, if you line everything up well, you're gonna get good healing. If you really and truly after all of that just still have like white bone, it's probably dead.
Yeah.
But I think it's very rare that you're in that situation. If you really do a good debridement, you'll get back to some bleeding bone. You'll get some ingrowth, and you'll get a good result from non-vascularized bone grafting.
Yeah, and I know at least I've heard some attending say that in these cases of the non-union, some cases, you definitely have to go and open up the non-union side and scrape out that sclerotic bone. But some others were saying that you can, pass the K-wire like you said, and then ream over the K-wire before you put in your screw, and apparently that's supposed to help with create some help, I guess, with the union, help create, break up some of the, I guess, that fibrous tissue and help with, unite that fracture. Is that something that you have seen used a lot, or I guess in your experience, that technique?
Just reaming over the K-wire as your way of stimulating healing. I think
Correct.
I don't know. I think you got to put some kind of graft in there. It doesn't always
Yeah.
have to be cortical. It doesn't always have to be iliac crest, but you have to do something, I think, to bring new bone cells in. And just reaming, in my personal opinion, probably isn't enough unless it's like, one of those ones where you still have like an intact cartilage shell, and it almost healed, but it didn't.
Right. And so when we first, when we have these non-unions, we start to think of these non-vascularized bone grafts. And again, so in what way, or what will indicate you to say, okay, we should probably be prepared to use a vascularized bone graft in this case? Is it just severe AVN, or what are some of the reasons why you would go and use one of these, vascularized bone grafts?
That's a tough question because you probably go in already with some sort of plan. You do a lot of planning for these cases, and you've probably decided what you're going to do most of the time. I would say a non-vascularized graft before you get in there. The times you're doing a vascularized graft, I would say you've probably already failed at something once, and this is like a secondary procedure. Um,
Right.
there's a lot of controversy about whether you can truly predict AVN on an MRI, even for a proximal pole fracture. So, I mean, if you think you see AVN on the MRI and you get in there and you've really cleaned it out well, you'll often see some punctate bleeding, and you realize you don't necessarily need to go to that vascularized graft. Um, but it's always good to have up your sleeve. I would say the most common one that people do is the 1-2 ISCRA graft. Um, that's probably the most popular. I've done it like once in my training, but most people, like I said, are sort of leaning towards the notion that the non-vascularized are okay.
And the 1-2, our CRA graft is at 1-2 intercompartmental supraretinacular artery.
One, yeah.
That one from the distal radius. And, I think you mentioned a little bit earlier about the medial femoral condyle vascularized bone graft that use the descending genicular artery. And I know there's a lot of different bone, like vascularized bone grafts you can use. You can go volar distal radius, dorsal distal radius, using, the volar carpal artery versus a different artery. Um, Now, one of the things we didn't touch base on is if you have this scaphoid non-union and you just do not treat it at all, they thought that they just sprained their wrist and they've had pain, but never really came to a doctor, and came to a doctor 3 or 4 years later, still complaining of wrist pain. What are some of the things that these scaphoid fractures can lead to?
So yeah, that's a big part of my conversation with patients. Again, because they're like, this bone is so small. Why do I care?
Right.
And I'll tell you, because it's the keystone in the wrist, and it goes on to give you SNAC wrist or scaphoid non-union advanced collapse. So I'll tell these patients that if they don't have it fixed and it goes on to non-union, they're going to be asking for arthritis type of procedures when they're in their 30s and 40s and trying to pick up their kids.
Yeah, yeah, and that's like, that's when you're talking about, styloidectomies versus fusions and proximal carpectomies, all things that they can avoid by listening to their local local
A whole
orthodoc.
nother can of worms, a whole nother podcast.
Now, what is your typical post-op protocol for these patients? Do you have them in splints? Do you allow them to range? When do you allow them to start to progress weight bearing, or I guess lifting things?
So I usually keep them in a cast, but I
Okay.
think people would keep them in, either a thumb spike orthosis or even a fracture brace. I just tend to have quite a few patients I can't necessarily trust, particularly the younger guys. They will, take off their brace more than they would like to admit. So I cast them. And these will, even with the screw for a regular scaphoid fracture or grafting the screw for a non-union, it typically takes about 8 weeks before they are really not having tenderness over the fracture site. But sometimes if they're feeling good at 6 weeks, I will let them start doing range of motion with therapy. You're always trying to balance stiffness and letting it heal. Um, so somewhere around 6 to 8 weeks, I'll let them start therapy, but I would keep them in some sort of orthosis when they're not doing their therapy
They're
exercises.
not doing that. Okay.
Yeah.
And are there any special, not special, but think considerations for athletes? And does that change, if this is a 25-year-old, guy that's on a professional NFL team that has this injury, does that change your algorithm at all?
For sure. And I mean, there's a couple of papers written on this specifically. For the young working patients or the athletes, we're going to go ahead and fix almost any scaphoid fracture, just to get them, back to work or play, without any delay. And then we'll typically move them earlier. So I think, more on the 6 weekend, we would stop doing any sort of complete immobilization and start range of motion. For like professional athletes, you might even let them go back around 6 weeks with some sort of protection, like a soft cast, depending on the sport. Um, so we're definitely more aggressive when it comes to those patients.
Okay, yeah, I think that's always a good thing to keep in mind, because I mean, like, for them, it's their career. Like, they gotta be able to try to get back or get it quicker to rehab, and definitely fixing these allows them to regain their motion a little bit earlier, and allows them to start rehab a little bit earlier compared to non-operative treatment with the cast, which you're in the cast for, like we spoke about a little bit earlier, yeah, at least maybe 6 weeks or so, and then you're still transitioning to a thumb orthosis, so that may be a little bit longer before you get back to on the field or practice, or whatever sport it may be.
Even if we let them go a little bit earlier to therapy, I would say most of us wait until around 10, 12 weeks to get our CT scan. So I almost always confirm on CT scan. I wouldn't say that's everybody's practice, but I think it's a good one, especially because, you can miss so much on an x-ray. And then biomechanical studies have told us that even just 25% healing is enough, is strong enough with a good screw fixation. But I would say most of us use about 50%. And I think in the clinical studies, 50% has panned out to be a good number. The question is, how do you really measure? You're just kind of eyeballing it most of the time.
That looks about right.
Exactly. So partial union, it's important to know that partial unions are very common. And if you've got, good screw fixation and about 50% of the scaphoid, it's going to be okay.
Well, Dr. Roberts, I think this was great. I think we touched on a lot of different high points as far as scaphoid fractures. We talked about the anatomy, we talked about the blood supply, the classification. We talked about, physical exams, what to look for in imaging, when to get imaging, what plane to get imaging in case there's any ED docs or any PAs or residents, listening to this. Just remember, get a CT in the long axis of the scaphoid. We spoke about non-operative treatment, operative treatment, and we kind of went over some of the different non-vascularized grafts that you can use, as well as some of the vascularized grafts as well. Dr. Roberts, is there anything else that you think is important for anybody to come away with listening to this talk on scaphoid fractures?
I think we hit most of the highlights. If I were going to give you some cautioning, I forgot to, back in the operative section, maybe just tell you about K-wire breaking.
Yeah.
So just be careful, because those K-wires are kind of flimsy. One thing you want to do is you can over drill on fluoro, so that you make sure you don't hit that distal cortex and pull your K-wire out. And you really want to sort of slide up and down the K-wire and make sure you're in line with the K-wire, so you don't snap it on your way out.
Yeah, and I think one more thing, and I think you touched on it a little bit, is that through our volar approach, sometimes in order to get the right trajectory, you sometimes have to go through that trapezium in order to make sure that you're, you want to get that 90-90 to whatever fracture line you get. Do you ever do that? And if you do, is there anything, does it ever worsen anything in that scaphoid trapezial joint?
No, I mean, I think that sometimes you'll read something about increased arthritis in that joint. I don't see any of that. I think it's totally fine to nibble a little bit of away to get a good start point. That's the most important thing for healing.
Well, awesome. Well, Dr. Roberts, again, thank you so much for coming on. And at the end of our talks, we always, give our guests a way for our listeners to reach you, whether you want them to follow you on social media, website, email, anything that you want to share. You don't have to, but if you want to, go for it.
I mean, you can find me on the Columbia Ortho website, and I'm happy to answer any questions via that you might have.
Perfect. Well, Dr. Roberts, again, we appreciate you so much for coming on the podcast. Great episode. And again, thank you so much.
You're very welcome. My pleasure.